Atrophic rhinitis. It is a chronic inflammation of the nose. Atrophic rhinitis is caused by atrophy of the nerve endings in the nasal mucosa, which in turn causes the atrophy or shrinkage of the nasal mucosa, turbinate bones, and seromucinous glands. This causes roomy nasal cavity and foul-smelling crust. This can be seen as primary atrophic rhinitis and secondary atrophic rhinitis. Primary, the cause is idiopathic, whereas secondary is followed by nasal pathology such as any granulomatous disease of the nose. This is most commonly seen in the females. Now we'll see primary atrophic rhinitis. The exact cause of it is unknown. The other causes can be remembered through pneumonic hernia. H stands for hereditary factors, that it can run through the families. E stands for endocrinal disturbance. As I already said, it is common in females. It is associated with estrogen hormone. So it starts with the puberty and it usually disappears or the crusting ceases after the menopause. Then R stands for racial factors. N stands for nutritional deficiency. This is important. It can be due to vitamin A, D, or iron deficiency. Then I stands for infective organisms. Klebsiella ozone is the most common one, which itself names the disease, as atrophic rhinitis is also known as ozone. And also so many other organisms such as diphtheroids, E. coli, Proteus mirabilis, etc. A stands for autoimmune conditions. Then we'll see the pathological changes. Ciliated columnar epithelium undergoes metaplasia and is replaced by stratified squamous epithelium. Then atrophy of seromucinous glands, venous blood sinusoids, and nerve elements can take place. Arteries in the mucosa, periosteum, and bone shows obliterative endarteritis. Bones in the turbinates undergoes resorption and shows widening of the nasal chambers, and the paranasal sinus becomes small due to arrested development. Clinical features. It is more common in female and starts with the puberty. The patient will be having foul-smelling nose and the patient will not be aware of it cause of the anosmia. This is called as merciful anosmia and it is a peculiar feature of atrophic rhinitis. Here the attenders will complain of foul-smelling nose while the patient won't be aware of it. The most presenting feature is nasal obstruction in spite of the wide chamber or roomy cavity. This is due to degenerative changes in sensory nerve, which causes paradoxical nasal obstruction. On examination, we can see full greenish or greyish black crust covering the turbinates and the septum as shown in this picture. On removing the crust, epistaxis can occur and roomy or atrophy of mucosa can be seen. As this is a normal cavity, when there is crust removal, the cavity will become roomy and the posterior wall of nasopharynx can be seen. The nasal turbinates is reduced to mere ridges because of the resorption of the bone. Then the nasal mucosa will be pale. When the crusts are left as such, it will intervene with the septal cartilage and cause septal perforation, and it can also cause saddle deformity of the nose, which is a rare feature. Atrophic changes in the pharynx is known as atrophic pharyngitis, and atrophic changes in the larynx is known as atrophic laryngitis, which presents with the features of cough and hoarseness in the voice. Patient may also complain of hearing impairment cause of the obstruction to eustachian tube and middle ear effusion. Paranasal sinus becomes small and thick-walled and can be seen as opaque in the X-ray. Prognosis. It persists years but recover in the middle age. Treatment. It have medical and surgical modalities. Under medical modalities, it aims in maintaining the nasal hygiene, removing the crust, purifying the smell, and check the crust formation. We can give nasal irrigation and removal of the crust using warm normal saline or making an alkaline solution by adding a teaspoonful of powder containing 1 part of soda bicarbonate, 1 part of soda biborate and 2 part of sodium chloride in 280 ml of water. And we should give nasal irrigation which will loosen the crust and remove the tenacious discharge. But we have to be cautious while giving nasal irrigation. We should avoid taking the liquid to the eustachian tube or the sinus. If the crusts are very hard, we should first loosen, then remove with the forceps or suction. We can also give 25% of glucose in glycerin solution for dissolution of the crust, and this can be painted in the nose to remove foul smell by removing the proteolytic organism. We can give antibiotics by spraying or painting the nose, which will eliminate secondary infections. We can give solution named chemicetin, which is a mixture of antibiotics, vitamin D2 and estradiol. This can be asked in MCQs. Estradiol nasal spray can be given mucolytics, which is 8 to 10 drops, which will liquefy nasal secretions, can be given, and we can ask them to add vitamin A, D, folic acid and iron in their diet. If the patient finds difficulty in doing repeated nasal irrigation and taking antibiotics, we can give them surgical intervention such as Young's operation, in which both nostrils are closed with nasal vestibule by raising the flaps, which can be opened only after 6 months. So for the 6 months, the patient will be breathing through the mouth, not through the nose, which will give them bilateral nasal obstruction. To avoid that, we have modified Young's operation, in which only partially nostrils are closed. Here we are giving the mucosa chance to revert back to normal and remove the crust. Then comes narrowing of the nasal cavity by inserting autologous fat, cartilage, submucosal injection of allograft, etc. We can also give Lawton-Schleicher method by medial displacement of the lateral wall of the nose. Thank you.